All right, so keep in mind that when you're doing these rehab strategies, these rehab exercises, the idea is that you are going to induce an improvement in functioning slowly over time. This is not something you're going to see improve immediately. And odds are, if you're doing these exercises correctly, you're going to probably fatigue the muscles to some degree. So their mastication or their deglutition directly after going through all these exercises might be worse. And why is that important? Because if the patient is easily fatigued, if you're going to, by going through all these rehab exercises, if you're going to put them in a position afterwards where their swallowing or their mastication is worse, then obviously you don't want to do that before a meal. You would want to do that after a meal. But in some patients, going through the exercises focuses their mind, wakes up their mind, as well as stimulates their muscles in their body, making them more likely to be successful with their meal. So with those patients, you'd probably want to do the exercises beforehand. So you would just operate according to the needs of the patient. All right, so let's move to buccal weakness. So you have a patient with hypotonicity of the cheeks. That is probably leading to buccal pocketing, meaning they're getting food stuck in their buccal cavities while they eat. A couple of strategies to increase the strength of the buccinators, the muscles of the cheeks. So for hypotonic flaccid patients, doing reps of ooh-ee, ooh-ee, and really trying to coach the patient to really purse their lips and retract their lips as hard as possible can work to increase the tension in the cheeks. Also, coaxing the patient to do reps of pulling their lips to one side and then holding it, and then moving the lips to the other side and then holding it in that position will increase the strength of the buccinators, hopefully decreasing buccal pocketing. So for reduced range of motion of the mandible, we've already talked about this to some degree when we spoke of fibrosis, trismus, if you remember. And we played the video of the guy that's having to stack tongue depressors in between his teeth and slowly increase the number of tongue depressors, slowly lowering, increasing the ability of the mandible to open, depress, or abduct. If you had a patient with reduced mandibular range of motion due to spasticity, then slow range of motion exercises, stretching exercises, the same that you would do with the lips and the tongue, with everything else to try to reduce spasticity, probably before going into a meal to see if that is going to increase their ability to masticate appropriately. So this would look like basically you just taking your gloved hand and pulling down, not too hard, but firmly on the mandible, and then moving a mandible from side to side, and then maybe in a circular range of motion to try to increase that range of motion, because that's sort of the rotary movement of the mandible during mastication. If you have a patient and the mandible is entirely hypotonic and flaccid, then it's going to be hanging open. For those patients, doing strengthening exercises for the mandible is going to be the way to go. So having them try to elevate the mandible against the resistance of your hand, or depress the mandible against the resistance of your hand. Lateralize the mandible against the resistance of your hand. And obviously working your way up towards some strategy, some activity where you're putting a bolus in their mouth that you're having them masticate, and that's going to be under a pretty controlled situation because you don't want them to anything to fall back into the pharynx beyond your control. And the bigger the bolus, the easier it is going to be for them to chew on it. So the smaller the bolus gets, the more effort is required of the mandible to masticate it. All right, so let's talk about delayed or absent swallow reflex. So different people have different definitions for what constitutes an absent swallow reflex or a delayed swallow reflex. The general consensus is that if the bolus rolls into the pharynx, and if the swallow reflex is not cued before 7 seconds passes, then you're into the realm of what is considered an absent swallow reflex. If it's under 7 seconds, then you're probably going to call it a delayed swallow reflex, and you're going to cite the number of seconds that the swallow reflex is delayed. And so you would, while you're doing the modified Barium swallow or the FEES, when you see that bolus roll into the pharynx, you're going to start counting. And you're going to wait for that swallow reflex to happen. And then when it happens, you're going to say 5-second delay on that swallow. All right, so now let's start moving into discussion of pharyngeal stage strategies. Some of these strategies, some of these exercises are appropriate for use with the bolus, with a real bolus, and some of them are not. Anytime you can safely be working on swallowing by having the patient actually swallow a real bolus, that is something you want to do. Having a real bolus in the patient's mouth, having them manipulate a real bolus, that is providing a sensory input to the brain that is going to make it much more likely that their nervous system is alert to what is actually happening in the body, and that it's going to do what is needed to do to accomplish a successful swallow. Whereas if you're doing the exercise without the sensory input of the bolus, which sometimes you have to do, then that patient's system is much less likely to respond as if there was a bolus there. And in part, this means the patient's system is not going to cue its best swallow. And when we talked about patients on ventilators and their muscles atrophying due to a lack of swallowing. So if the lack of swallowing facilitates degeneration of that ability, then the presence of actually swallowing is going to facilitate improvement of that. So it's always important to recognize that you get better at a task by doing that particular task. So when you're working on artic therapy, you get better at producing that phoneme by practicing that phoneme. Just like you get better at swallowing to some degree by practicing that swallowing. So as soon as you have worked the patient up to be able to where you can perform therapy with the presence of a real bolus and the patient safely swallowing that bolus, that is what you're shooting for. Because the patient's going to get better at swallowing food and liquid by practicing swallowing food and liquid. So we use an effortful swallow or a hard swallow in a couple of different ways. We use it as a compensatory mechanism, but we're also able to use the effortful swallow as a rehab exercise, as a rehab strategy to strengthen the pharyngeal muscles and all the muscles that are involved in the pharyngeal process of the swallow. And usually I cue this by just saying, all right, I want you to swallow hard, swallow as hard as you can, put as much effort into it. And I really give them a facial expression and I let them see the tension in my neck as I'm doing a dry swallow. And if we're using this as a rehab strategy, basically as a repetitive exercise, then you're going to be cueing them to do probably dry swallows or maybe like little half teaspoons of honey thick, for instance, something that they're able to safely swallow. And the effortful swallow as a rehab strategy is really, when done correctly, is really going to facilitate the hyolaryngeal excursion, pharyngeal constriction, and lingual retraction. So for those patients that you see stasis in the pharynx after a swallow, this is a good strategy to put into place for a compensatory measure, because when they go to use the effortful swallow, that's going to really tense everything up more than it was. It's going to facilitate that constriction, which is going to clear all of the bolus, not allowing any stasis to stay in the pharynx. And that would be the compensatory benefit of the effortful swallow. And then as they're using the effortful swallow to compensate for their stasis in their pharynx due to a lack of pharyngeal constriction or for the presence of reduced hyolaryngeal excursion or lingual retraction, as they're using the effortful swallow as a compensatory strategy, they're also exercising all those muscles with every swallow, which will over time increase the strength of all the associated muscles that are being worked. So the effortful swallow, therefore, acting as a rehab strategy as well. So as an SLP, we're often recommending effortful swallow. That's one of our go-tos. That being said, you want to evaluate the effectiveness of the effortful swallow during your instrumental assessment before, if you're going to continue to use it as a compensatory measure. You could feel free to use it as a restorative measure, even if it's not working as a compensatory strategy for a patient, because over time, that exercise is still going to strengthen those muscles. Also, bear the warning out right here below, which is that effortful swallow, they can be fatiguing. And if you're doing this during a meal, if you're encouraging a patient to do this during an entire meal, across an entire meal, then they can be fatiguing their muscles during their meal, which is going to make their swallow worse, because towards the end of their meal, they're going to be trying to swallow with muscles that are now fatigued. An example of how you would implement this as a restorative exercise is that you're always going to want to see what the patient is capable of, and then you're going to work up from there. But an example would be just generically, patient will complete 10 effortful swallows 3 times a day. So 3 sets of 10. And as I already mentioned, the effortful swallow used as a rehab exercise, it requires consecutive swallows. So you have to swallow, and you have to do it again and again. And having a bolus to do that with makes it much easier for the client than just doing dry swallows or swallowing their own secretion, which the body really stops allowing you to cue your swallow reflex if you try to do too many dry swallows right up close to each other. Contraindications for the effortful swallow would be a client that has some serious cardiac conditions. So you would be basically cueing the client to bear down a little bit, which could increase blood pressure. And that could be a bad thing depending on the client's medical situation. So you want to keep that in mind. A couple of different ways you could illustrate the effortful swallow to a patient using biofeedback. The most obvious would be having the client feel your throat, the muscle tension in your throat, the hyolaryngeal excursion in your throat as you do normal swallows, and then as you do effortful swallows. And then you have them feel that on themselves and see if they can monitor themselves for appropriately producing an effortful swallow. And you could also do this during a FEES, not during a modified barium swallow, because as we mentioned, that those individuals are catching radiation the entire time they're in there. But during a FEES, oftentimes as SLPs, we'll keep the patient in the chair with the camera in their nose for quite a while trying different things. So having the camera in their nose, showing them on the screen the difference between the stasis in their pharynx during a normal swallow versus an effortful swallow would be a good way of illustrating to them, giving them a form of feedback that shows them that they are correctly doing the effortful swallow. All right, so now let's talk about Misako. And we've talked about this already to some degree in this class. So the Misako maneuver, also called the tongue hold maneuver, there's a couple of different ways of doing it. The most obvious is that you have the patient stick their tongue out and then bite on their tongue, holding their tongue in place. And then you cue them to swallow. And if you do this yourself, when you do it, you will feel your tongue wanting to retract. You'll feel your tongue wanting to retract, and so it'll be trying to come back. And you'll also feel, because you're changing the normal physiology of how your swallow happens when you're holding your tongue in the protruded position during a swallow. Also, when it happens, you're going to feel your posterior pharyngeal wall reaching further anterior to try to make that contact with the tongue that is now not retracting as far because you're holding it anteriorly. You could also hold the patient's tongue with gauze as they did this, or you could teach them to hold their tongue with gauze. And the further their tongue is protruded, the more the tongue will want to, the harder it's going to pull back to try to get that lingual retraction during a swallow. And the further, the harder the posterior pharyngeal wall is going to be, the harder the posterior pharyngeal wall is going to be working to move anteriorly to contact the back of the tongue. So the Misako maneuver is implemented to increase lingual retraction and to increase the anterior movement of the posterior pharyngeal wall during a swallow. So we're talking about constriction of the pharynx during a swallow and increasing that via lingual retraction and posterior pharyngeal wall moving anteriorly. And you can pair Misako with an effortful swallow to make it to be trying to work to try to be working the muscles that much more for the purposes of restoration of their function. This is not a strategy that you want to be practicing with the patient having a real bolus in their mouth, because essentially you're going to be cueing them to swallow a bolus using a changed and maladaptive physiology that you have induced, which is going to make them more likely to aspirate. So you don't want to have the patient to have a bolus in their mouth during Masako. You're not going to use Masako during meals. The most you could do is be moistening the oral cavity with a toothette or lemon glycerin swab between swallows. For those patients that are at heightened risk of penetration and aspiration because of lack of vocal fold adduction due to flaccidity or hypotonia. So this is not for your hypertonic spastic individuals. Trying to do exercises that are going to cue the patient to practice and repeat appropriate vocal fold adduction. One way to do this is cueing the Valsalva maneuver. If you remember from anatomy, we talked about the Valsalva is when you go to pick up something and your vocal folds automatically close to make your thorax rigid for the purposes of picking something up. So when you go to lift something, you do that. You hear your vocal folds come together. That is one way to cue vocal fold adduction. So having them lift or push against something will reflexively cue adduction. Sometimes having them push their hands together like this cues adduction. And then having them sustain a phoneme as they are adducting. Ah, a nice, strong, normal phoneme that is indicating to you that the vocal folds are appropriately adducted. At least enough so for the production of voice. You don't want to do this in patients that have high blood pressure. So your cardiac patients, your stroke patients. You don't want to do anything like this in your patients that are prone to hyperadduction of the vocal folds. So this means your hypertonic or your spastic patients. Another exercise we used to do all the time was having the patient produce a glottal coo repetitively. So, having them do 10, going to another exercise, and then coming back to that. So these could be useful in remediation of a lack of adduction due to flaccidity. And you're just working on adduction, not necessarily adduction during swallowing. So these could be the strength that you are cueing to be rebuilt, and then the muscles of adduction would translate into better voice and better swallow. All right, so let's talk about supraglottic swallow and the supraglottic swallow in the context of a rehab exercise for encouraging better vocal fold adduction. These strategies are elegantly used as exercise and then possibly segueing them into a compensatory strategy. But essentially what the supraglottic swallow is you take a breath, you hold your breath, and you swallow. And then after your swallow, you begin breathing with the onset of a cough. So it looks like Now, because you are cueing someone to cough, you want to be wary of the possibility of eliciting vocal abuse. But the supraglottic swallow is nice as a rehab strategy, as a rehab exercises, because it cues the adduction of the vocal folds during the swallow, and then afterwards you cough. That would clear any secretions that got into the airway during the swallow if you weren't using a real bolus with it. If you are using a real bolus with either of these, you've probably transitioned more into teaching these as a compensatory strategy. The supraglottic swallow is exactly like the supraglottic swallow, except you're basically pairing it with an effortful swallow. So essentially, you're going to tell the patient, all right, I want you to take a deep breath, hold your breath, and then I want you to swallow hard and then cough. So the supraglottic swallow looks like so it combines the airway protection mechanisms of the supraglottic swallow with the strength building effort, the effortful swallow. And the hardest part of these strategies to get the patient to be able to accomplish is the breath holding part. And obviously, if the patient is like compromised in a respiratory fashion, then you're not going to be able to use this, or maybe be able to use it in a much more reduced fashion. You don't want them to hold their breath for long, just long enough to hold their breath, which is going to cue adduction, and then swallow, which is going to cue the bolus passing safely over the airway, and then initiating respiration again with the cough, which will expel anything that has been penetrated into the airway safely out of the airway. So keep in mind, if you're using these as a drill-based exercise to cue vocal fold adduction, or if you're using it as a compensatory strategy to increase airway protection during swallowing, like during a meal, keep in mind that if I ask you to sit and do this 10 times, either of these, you're going to find that pretty fatiguing. So for a patient that is medically compromised, it can be very fatiguing. So just keep the fatigue factor in mind, because you would not want to fully fatigue a patient during swallowing therapy and then ask them to start eating a meal. Okay, so the next strategy we're going to be talking about is the Mendelssohn maneuver. Mendelssohn is not a compensatory strategy, and you'll never use it that way. It is for restoring the hyolaryngeal excursion, and it's very good at that. And also, let me emphasize that as the larynx elevates, so that if the UES is staying in the same position, when the larynx elevates, it is that in part the elevation of the larynx which helps increase the opening of the UES, which facilitates the bolus getting safely into the esophagus. So these two things sort of happen together. Hyolaryngeal excursion with dilation of the upper esophageal sphincter. Those two things happen simultaneously, and they're physiologically linked. So what the Mendelssohn maneuver is, so if you swallow, you will feel your larynx raise and drop back down. And so you would instruct the patient to feel that on you and then on themselves. And then you would say, okay, this time I want you to swallow, but see if you can keep your larynx from dropping back down. So and then dropping it back down. So swallow, hold the larynx up, and then let it go. So you're working the muscles of the suprahyoid muscles more than usual, which is going to strengthen them. And if you have reduced ability, if you have weakened suprahyoid muscles, then by strengthening them, you're going to increase their ability to elevate the larynx during the swallow, which should also facilitate dilation of the UES. Once again, you will not use the Mendelssohn as a compensatory strategy. You will not use a real bolus with it. Although you could use a wet toothette or a wet lemon glycerin swab to give the patient something wet in their mouth to swallow, or to cue saliva production for the swallow their own secretions. All right, the next strategy we're going to talk about is the shaker. And this is not a compensatory strategy. This is an exercise. You will have the patient lay flat. So if they're in a bed, you're going to put the head of their bed down. Once the head of their bed is down, you cue them to raise their head and look at their feet. And you want them to hold it for 30 seconds to a minute, and then let them put their head back down. And then cue that same thing, raise your head and hold it and look at your feet. And you want them to hold it for 30 seconds to a minute. And then they're allowed to put their head back down. And then you want to cue them to raise their head and look and drop their head. Raise their head, look, and drop their head 30 times. And this is strengthening extrinsic laryngeal muscles. It strengthens pharyngeal muscles. And you can imagine, if you were cued to do this, that you're going to feel that it's a pretty serious exercise. So you can imagine that many patients really do not like doing the shaker.